Hi, good afternoon. Thanks so much for joining us today. My name is Krista McLaughlin. I'm the Director of the Medical Informatics Unit for the Office of Population Health and Evaluation. I'm joined today by a few of my colleagues. I have Michelle Rahm, who's going to be assisting me in answering any questions that come in during today's training, as well as Janine Carrazzo and Noah Isaacs, who are assisting us from the program side of things, especially related to all things hospital. So I just want to just jump ahead because as you can see from our agenda today, we have a lot to get through when it comes to all things PSYCKES and how this tool can be used to help you in your work at the hospitals. If you do have any questions that come up during today's training, please make sure that you're entering them into the Q&A box that's located in your WebEx menu. If you expanded your screen to the full screen, you'll just want to hover your cursor over the top bar and select the Q&A function. And we're going to save our questions to the end of the training to make sure that we have plenty of time to get through all of these slides. But if we don't happen to get to your question during the hour that we have today, please do not fret. We are going to be tracking all of the questions that come in today and following up with our users. So with that, let me go ahead and get started. So for many of you, you already know what the PSYCKES application is, but for those of you who aren't as familiar, the PSYCKES application is an online web-based application which is secure and HIPAA compliant. And the main purpose of the application is for sharing not only Medicaid claims and encounter data, but other state administrative data. And we do this by putting this data into a user-friendly format. And the application is designed to support data-driven clinical decision-making as well as quality improvement. And we have a couple different reports that are available in PSYCKES. The clinical summary is updated on a weekly basis, and that's based on that one individual client, versus the quality indicator reports that gives you an idea of what the performance is per your hospital, per your network, and this is going to be updated on a monthly basis. So now that we know what PSYCKES is, who am I going to be able to view in the PSYCKES application? So the population that's available in PSYCKES is at this time the Medicaid behavioral health population. So that's including those Medicaid enrollees within New York State, and this is including those who are both currently or previously enrolled in Medicaid. And this is fee-for-service, managed care enrollees, as well as those who are dual eligible. One small note about the dual eligible folks is that, let's say, for example, someone who has both Medicare and Medicaid, that might mean that we might not have as much information because, for example, if we can't see the Medicare data, and oftentimes Medicare might be the one that's paying for medications, we won't be able to show that information. But any of the claims that are paid for by Medicaid, we would be able to display that. I do also want to make mention of the second part of that population, the Medicaid behavioral health population. So what do we mean by behavioral health? That means that the individual would have to have at least one psychiatric or substance use service, a psychiatric or substance use diagnosis, or any psychotropic medication. But once the client's in that population, the information that you'll have to see on that individual is across the treatment spectrum. That's including general medical, behavioral health, residential, and as you see in my first bullet up at the top here, we have over 12 million unique New York State Medicaid behavioral health individuals available in the application at this time. All right, so now that I know who's going to be available in my view in PSYCKES, what data am I going to be able to see on them? So that clinical summary, as I mentioned before, is providing up to 5 years worth of data on an individual client. And I just want to make sure I'm reiterating this part. This is also updated weekly. Now, the client information that we're getting is coming from two different types of data sources or data buckets, as we like to refer to it. Our largest data bucket is the billing data, which is that Medicaid fee-for-service claim and managed care encounter data. Now, just to make a quick note about the Medicaid data is that it's important to understand the different aspects of our data sources. So it really first depends on where it's coming from. So Medicaid is coming from billing claims, right? So there's going to be a lag when you're thinking about anything that has to do with billing. but it does really depend on the type of service it is. So something like pharmacy claims, we actually consider those pretty quick and timely from the time that somebody has picked up their prescription at the pharmacy to the time that it shows up in PSYCKES, can be anywhere as little as 30 to 45 days. I've actually seen some for 2 weeks. So that's actually information that's pretty quick and timely. However, other information like inpatient and outpatient services tend to take a little bit longer from the time that the service occurred to the time that you'll be able to see it in PSYCKES. I think on average, I mean, I've seen as little as 2 months, but there could be other times where it's like 3, 4, maybe even more months. And that's because of a couple different things. So first, it depends on how quickly and accurately the provider themselves bill for the service. So some providers might have a billing practice where even if a service started on the first of the month, they do all their billing at the end of the month. So that's already adding a month onto that billing lag. Then let's say that they have to submit it to the managed care plan. The managed care plan has to review, they could send it back, and then it moves on to the Department of Health. So once it gets into the Department of Health feed, that's when we're able to pull that information on a weekly basis. So it just depends on sometimes how long it takes to get into that feed, but we do refresh that feed monthly. Now, the other data sources that you're seeing here is more of what we call our quote-unquote real-time data sources, and these are coming from other state administrative databases. And we're able to refresh this, as you can see here, as little to a 0 to 7 day lag. So we update the information in the clinical summary on a weekly basis, and all of this information that you're seeing here is also updated on that weekly basis. So what is some of this information we're getting outside of Medicaid claims? So we're getting information from the New York City Correctional Health Services. So if somebody was in Rikers and was receiving, behavioral health services, and they got an appointment after they were discharged, that's going to be information that you're able to see in PSYCKES. Same with New York City Department of Homeless Services. So if somebody has been captured in the data for Department of Homeless Services, whether that they had a shelter stay or they're in outreach, that information is going to be reflected in PSYCKES, including the name of the shelter, the borough, even a contact. We also have health home enrollment and care management agency provider information, and that health home enrollment is also including a contact. So we're all about trying to make those connections for care coordination, and that's something that you're going to see at the very top of the clinical summary. We also have the managed care plan and HARP status, managed care plan assigned PCP. We also integrate the State Psychiatric Center EMR data directly into PSYCKES. We also have information coming from TACT for AOT provider information, as well as ACT coming from CARES. We also have adult housing and residential program information. We also have suicide attempts that we're getting from the state's incident management system. And unlike Medicaid claims, which does have that 5-year limitation, something like suicide attempt, we deemed it was it's such a critical piece of information that this is going to extend further back than 5 years. So if somebody had indicated that someone had a suicide attempt in NYMERS into that incident management system for the state, they submitted that 10 years ago, 12 years ago, that information is still going to be able to be displayed in PSYCKES. We also have the ability for providers, as well as clients themselves, to enter in safety plans or psychiatric advance directives, which would be available within the clinical summary for that individual. There's also screenings and assessments that can be done. So a suicide screen or a depression screen, that is also a tool that can be done in the My Choice or in any of our mobile applications. And we also have intensive mobile treatment and AOT referral under investigation. We're getting that directly from DOHMH. And there's a lot more data that's coming our way too. We're also in the process of integrating the mobile crisis information directly from Maven, as well as the crisis residential. So all of these different data sources are coming together into one user-friendly view into that clinical summary. So you have that one-stop shopping in that view to see this integrated view of services and medications. All right, now let's talk about the quality flag. So OMH has identified a number of health conditions or treatment issues that were deemed important enough that they were worth scrutinizing. So what PSYCKES does is that it tracks these clients who are positive for one or more of these health conditions or treatment issues. That way the provider, the managed care plan, or local county and state government leadership can be made aware and take the necessary steps and maybe develop an intervention. So these flags can assist with supporting clinical review as well as quality improvement. So here's just an example of some of our flags here. So having an understanding of who's health home enrolled or eligible for Health Home Plus services, medication related, somebody who's on multiple antipsychotics, multiple antidepressants, or those that aren't actually adhering to their medication, that they're not on their antipsychotic medication for 80% of the treatment period. We also have a lot of the hospital-related flags. So high utilization, people who are, going in and out of the hospital with that readmission flag, or people who are going to the hospital 2 or more, 4 or more, 10 or more times in a year. That's going to be captured within these flags. We also have the general medical. So people who didn't get a diabetes screening while they're on an antipsychotic, and those who haven't had an outpatient medical visit in over a year. We also have some of the performance tracking measures, which are run by DOH, and those have a little bit of a different look-back period. They have a delay of a 6-month maturation period, but those are also some of the hospital-related measures, right? So people who aren't getting that really important and necessary follow-up after an inpatient stay or after an ED visit. So those are really key metrics that you're able to track within the PSYCKES application. So this is just a little summary of some of the reports that I kind of touched base on. So the individual client level reports, that's that clinical summary where you're able to get all of that integrated data sources in that one view for over 5 years worth of information. But then we have some of this more population provider level report. So the QI report is there to review your current performance on all of those different quality indicators and have the ability to drill down to the client level view to see, out of the people who are hitting this flag, who are they? And then we also have the recipient search where you can run ad hoc reports to identify cohorts of interest, like maybe people who are considered complex needs. So that's another way that you can, track that really important information. We also have usage reports, right? If you don't use it, you lose it. So it's a really great, especially for hospitals wanting to integrate PSYCKES more and more, this is a great way to track to make sure that your users are actually accessing the application. You can also monitor the PHI access that people have access to in the application. And then we have the utilization reports that are really helpful to help identify who else in the community is working with my clients. And then we have those statewide reports, which allow you to select an indicator and then look at the statewide proportions based on the region, the county, the managed care plan, the network, even down to the provider. So these are all reports that we're going to be reviewing today. So before we get into all that, we got to know, how do I access this really important tool to help me do my work? So every hospital in New York State is eligible for PSYCKES access. So there's not going to be a time where we say to a hospital, sorry, you're not eligible, you can't have PSYCKES access. Every hospital is allowed to have PSYCKES access. The question is, did they get the access? Did they follow through the access protocol to make sure that we have this tool available to us? If your hospital does have access, that access is going to be managed by your hospital security managers. So the security managers were appointed by hospital leadership. And we actually recommend for like hospitals, right? There's a large group that's a lot of users potentially. So it's probably a good idea to have multiple security managers, right? So if Helen goes on vacation for 2 weeks, we're not stopped and no one can get access to PSYCKES. That's going to be one of those things that you want to have available to you. And that's another thing I want to make sure that people are really aware of. PSYCKES is granted at the organizational level. So if somebody in the ED department has access to PSYCKES, that means that your hospital, if you're working in the inpatient, you are also allowed to get, well, allowed is an interesting word, but you would be eligible to have PSYCKES access because your organization already has the access. We don't grant it at the service setting or the program level. It's granted at the whole hospital level. So what you'll want to do is make sure that you're reaching out to your security manager to see if you could get your access granted to PSYCKES. If you're not sure who your security manager is, totally fine. Email the PSYCKES help desk, and we're going to have that contact information I think on our last slide of today's training, and these slides will be emailed to everybody who came today, so I just want to make sure people are aware that they're going to have that as well as the recording. Once you are granted PSYCKES access by your security manager, you're going to be sent a self-service console instruction email, which is sent to all new users, and it provides you your user ID as well as a temporary password to log into this console. And you need to log into this console in order to obtain your token. Also, if you leave the hospital, the security manager really needs to make sure they're revoking access, right? Because if this person's no longer associated with my hospital, I wouldn't want them to be able to access patients that are in the hospital, access their, their protected health information. So just like you would have someone hand in their pass keys, you want to make sure that you're revoking access. Now, for hospitals that don't have PSYCKES access, this is what they'll need to do. They'll need to complete and return documentation to the PSYCKES Help Desk, which includes the PSYCKES online contact form. We also need to have the CEO or ED sign the PSYCKES confidentiality agreement, and then we provide implementation tools. So once we have those two pieces of information, we're off to the races. So the next thing that we'll have to do is have the CEO or ED sign what's called the confidentiality non-disclosure agreement, which is what everybody has to sign in order to use the OMH security management system. Designate a security manager, and then you can start enrolling PSYCKES users. All right, so let's say I've gone through the process. I have my user ID, I have my token. Now I'm going to go ahead and log into PSYCKES. So you're going to go to the PSYCKES website at psyckes.org or psyckes.com, and you're going to select the login button right here. From there, you're going to get prompted to say, are you an OMH provider or are you an external local provider? So if your email doesn't end with omh.ny.gov, right, then you're going to be using the external local provider option here. From there, you'll enter in your username, which you will be provided when you were granted access, and then you're going to indicate the passcode. And this is the interesting thing for hospitals, right? Because there are some hospitals that have some restrictions in place because there's two different ways to get a token. So the most common way that most people get tokens is a mobile token. Why? It's because they have the ability to have it quickly pulled up on their phone and they can take it wherever their phone goes, which for most people is everywhere they go. So if you have a mobile token on your phone and you pull that up, what you would do is you would put in the PIN that you created onto your token, and then you would generate a passcode that expires every 60 seconds. However, again, there are some restrictions in hospitals. Some people aren't even allowed to have a cell phone on the floor. So for those users, they would have a hard token, which we're seeing up here, almost looks like a keychain. So what they would do is they would indicate the PIN first in the passcode field, and then enter in the 6 digits that they get generated from the token every 60 seconds. So even if you are in a hospital that doesn't allow cell phones on the floor, you would just make sure that you're requesting a hard token. All right, so now that we know how to get access to PSYCKES and how to log in, let's talk about how to use it. So the recipient search we already touched base on. This is a great way for you to be able to get information about a cohort or an individual client. So for that cohort search, the number one thing you're seeing here is the complex needs, right? So just this past month, we added a new feature in PSYCKES, which allows users to not only identify who of their population is considered complex needs, but now you're actually able to select by the different criteria that make up complex needs. And one of my slides is going to go through this in more detail. But some of the other things that you're going to be able to use the recipient search for. If you want to have you want to identify who's the high costing Medicaid folks that are using the inpatient ER. Who are the people who have been identified as homelessness or homeless based on maybe the New York City DHS data or via Z codes in billing. If there's any significant alerts like a suicide attempt, suicidal ideation, opioid overdose, quality flags, service settings. Maybe I'm a very large organization and I'm only interested in the ED department. I don't do anything with the inpatient department. You do have the ability to filter for certain service settings, so you're focusing on your individuals that you're serving. We also have the ability to enable access on your different searches, and we're going to go through that process in a moment. And then there's also advanced views. So instead of having to drill into individual clinical summaries to get an idea of who would be considered high need, high risk, or what would be some of the care coordination information I'd like to know, or hospital utilization, you can put on these advanced views. All right, so now let's take a look at the screen that we're seeing here. So up at the top, you're seeing individual search. So this top box here is what you would be using to look up one individual person. So if you had their Medicaid ID or their Social Security number, that's that unique identifier, or if you want to search by a combination of their name and date of birth. And you can search for those people, like maybe this is a brand new person who's coming into your emergency department. You want to search the full database, or if this is John Doe, who I've seen multiple times, instead of searching the full database, maybe I just want to look at Main Street Hospital because I know that that's where he's been served. Underneath that section is the group search. So that's that cohort search function that I was talking about. So if I'm interested in looking for people that I've served in my population in the past year who have this condition, this diagnosis, this special population, you have the ability to do so here. And the great thing about the recipient search is it helps you build out from the largest search to the very most narrow. So let's talk about some of those different search options. So we have this special population section, which allows you to search for a couple different things in here. So if you're trying to identify who have I served that is considered OPWDD services eligible, who have any OMH outpatient specialty services, who are considered behavioral health high need dual, these are some of the searches that you can run right at the top of population. Next, we have the high need population filter. So what are some of the things I can search for in here? So high Medicaid inpatient ER costs. So who's costing the state the most, the 1% or the 5% of people utilizing the inpatient ER that frequently? That's the way you can search for here. Or if you're interested to identify who's the high fidelity wraparound individuals versus our Health Home Plus individuals, that's another different search that you can run. But as you can see, there's a lot of different options that you can choose from this individual box in this dropdown. Next, we have alerts. So if I'm interested to identify, like, who have I served in the past year who had a suicide attempt in the past year or ever, or anything to do with overdoses, or have been an OMH unsuccessful discharge, this is another drop-down that I could utilize. And then next, we're talking about the homelessness alerts. So these are specialized alerts that's mixing two different data sources here. So we have the New York City Department of Homeless Services that we are able to get information from, and we get Z codes from Medicaid billing that lets us know if somebody indicated that this person had any history of unsheltered or sheltered homeless issues, that would be indicated in this drop down here. And then we get to the complex needs. So I'm just going to jump to this next slide here just to give an example. So here's all the different criteria that make up somebody being complex needs. So if they have one of the following in the general criteria, or one of these in the additional eligibility criteria for that certain age range, this would make somebody be considered complex needs and get that complex needs flag. So what we did with this criteria is we created a brand new filter box, which allows users to not only search to see, like, of my population I served, how many have any kind of complex needs, but you can also go one step further and say, of the people who have complex needs, how many of them have it due to being ACT enrolled or discharged in the past year, or homelessness in past 6 months, and SMI. So you have the ability to use this search. Now, when you're picking within this list, it's going to create an OR criteria. So if I'm selecting AOT active expired in the past year or active enrolled, right? So that's what's happening when I would do a double click here. But this is another example of another filter option that folks have available to them. We also have social determinants of health that we're getting, like I said before, from those Z codes. So if you wanted to identify a specific type of condition, you could come in here and even expand the tree, as you can see over here. So problems related to housing and economic circumstances. Maybe I'm interested in certain conditions underneath that domain. Then we also have quality flags. So any of the quality flags you can also search for. So if you're a hospital user and you want to know, of the people that have been served in the past year, how many were due to 10 or more ER for mental health cause? And you can select, again, more as up to 4 quality flags per search. But again, that's going to create an OR criteria. And then we have medications and diagnoses. This is not only allowing you to search by a specific medication, but you can also search by a specific drug class. And you can also search by either a diagnosis domain, or you can click inside and open up that tree for a specific type of diagnosis, or you could even type in the ICD-10 code or use a fuzzy logic of searching for the name of a particular diagnosis. So that's another type of search that you can add on and create these really interesting cohort searches for yourself. And then we have the ability to do searches either by a specific provider. So if I'm logged in as Main Street Hospital, I could run searches based on the services that I'm providing underneath my organization, or I could run a search for services by any provider in the state. And I could focus that in on a specific region or county. I could focus that in on a particular provider. I could also figure it out for a specific type of service utilization. So if I want to know who have I been serving in the past year that had an ER, behavioral health, ED visit or CPEP visit of 10 or more in the past year, that was really high utilizer, I could do so by running a search like this. But let's do a couple example searches. So the first one I want to make sure that people are aware of is, how can I identify the population of my concern? So if I'm working in the emergency department, maybe the first thing that I want to do in a recipient search is identify, okay, in the past year, how many people were served at Main Street Hospital in my emergency room for any cause? So that's what this search is showing me right here. It defaults to the past year. This is my provider because I'm logged in as this provider, and therefore I only have access to people that I've, served. Here is where I have the selection of, like, if I wanted to do any ER visit, or if I wanted to make a selection for different types of ER visits. So I'm going to run this search to give me almost like a denominator, right? So in the past year, Main Street Hospital has had over 12,000 recipients that have been served in their ER. And I would be able to see that list here. Now, let's say of the people that have been served in my ER in the past year for any cause, I now want to know, of those people, how many are considered complex needs. So I have the option of selecting complex needs here, and now I'm going to layer this onto my search. So now I can identify, of the people who I've served in my ER in the past year, how many are considered complex needs for any reason. So now you see that number is now like 1,200. So that's about 10% of the people who went to my ED for any reason in the past year. Only about 10% of them were considered complex needs. Now I could even take this search a little bit further. I could say, okay, of the people that I served in my ED for any reason in the past year, how many are complex needs due to being ineffectively engaged, having no outpatient mental health visit, and having 2 or more inpatient mental health or 3 or more ER mental health? So of those people, 67 recipients were found. So maybe that's something that I want to be able to work on. It's like, I want to make sure that I'm making those connections and making sure that people are getting those outpatient services before they leave, the ED or the emergency room from my hospital. So let's say from that list, the 67 recipients, I'm kind of curious, like, so they're ineffectively engaged. Maybe there's some other type of high need or high risk that they might be eligible for. So one of the things that you can do is actually input a advanced view. When I hit this I button here, you're going to see that I have a couple different options. So the standard view is basically seeing the name and all of the other client identifying information, and then what other quality flags that they might be eligible for, or I'm sorry, that they actively have. Then you can put on different results. So if I wanted to see of these 67 recipients, what's their care coordination looking like? What's their hospital utilizations looking like? And what are their outpatient providers looking like? But for this example, I'm gonna put high need, high risk. I wanna know what other high need, high risks they might have. So I'm gonna place that on. And then you see that I'm running the search, and I can see of these, what my current PHI access is. So that's another thing that I do wanna mention, is that if you have no access, so there wasn't a consent and it's not an emergency, you're not gonna be able to view information for this client outside of their name. So scrolling from left to right, I can see who had an OMH unsuccessful discharge, who is a transition age youth, who is considered OPWDD-NY start eligible, who has a high fidelity wraparound flag, who's considered Health Home Plus eligible, any of the homelessness criteria that we have in the past year or any, AOT status and that expiration date, any suicide risk, and if you're seeing a yes, that means that they do have some sort of evidence of that in their clinical summary. You have the overdose risk and then the PSYCKES registry. So again, you have this option without having to drill into the clinical summary to get a little bit more information about this group of people. So now that we've talked about the recipient search, let's make sure we know how to access client level data. So clients are going to be linked to your organization one of two ways. So there's the automatic linkage that comes from a billed service. So if you're billing for a client for a service, they're going to be attached to your organization. Then there's also the manual. So this is when the client is either signed the PSYCKES consent form, the DOH Health Home consent form, or the BHCC consent form, but there's then a verbal consent provided. There's a clinical emergency, or the client is currently being served by or transferred to your agency. So these options here, somebody manually has to indicate this in PSYCKES, but each of these options have a different level of access that they could have to client data. So for signed consent, that's the gold standard. That's what is going to allow access to all available data, including data with special protections like SUD, HIV, family planning, genetic testing. And what it does is it allows that level of access for at least 3 years after the last billed service. So if this is somebody who you're going to consistently be seeing on an ongoing basis, that 3 years keeps getting pushed further and further into the future because it's 3 years from the last billed service. This is also assigned consent is under the entire organization. So if a consent form gets signed in the ED, that consent is also good in the inpatient, also good in your clinic. So this is the signed consent is for the entire organization, not by program. Then we have the verbal consent. The verbal consent, so maybe the client verbally consented, but they didn't write the consent, they didn't sign the consent form. That would allow access, but limited access. It's only going to allow access to data for 9 months, and it excludes data with special protection. So you wouldn't be getting the full picture, and it would only last for 9 months. We then have the clinical emergency, right? Someone shows up in my ED, maybe they're in such a crisis that this is not going to be something where they're going to be able to sign the consent form, and they're at risk of harming themselves or somebody else. It's an imminent risk that they could harm themselves or somebody else. That's when we have the break the glass situation. So this allows our providers to access all available data for that client, including special protected information, but for that limited duration of 72 hours. So if a client is at risk of harming themselves or anybody else, that's an imminent risk, that's when you would want to utilize the situation. And then hopefully after some time has gone by, maybe you can always revisit that consent option. Lastly, there's the attestation of service, apologies, and that is just basically the client didn't sign a consent form, it's not an emergency, and they didn't verbally consent. You can link them to your organization, but again, by linking the client to your agency, it's not going to provide you any clinical summary information. It's just going to be like, I know this person's part of my organization, but it's not going to be able to provide you the level of access that you would need to get to the clinical summary. All right, so let's talk about how do I enable access. So first you would search for the client. And again, using a unique identifier is the best way to get only one person back, right, ideally. But again, you do have the option of using a combination of name and date of birth. So here I search for somebody using their Medicaid ID. I would just want to make sure that I'm confirming that Jane Doe, this is the Medicaid ID, that's her date of birth, that's her address, all of this looks right, then I can enable access. If it's not a match, you'd want to modify the search. All right, so the first thing I have to do after I've found my person is what level of access do I have to Jane's information? Did she sign the PSYCKES consent form or another one of the consent forms? If she didn't sign a PSYCKES consent form, did she give a verbal consent? Or is this an emergency and I have to break the glass? If it's none of these above, am I just saying that, hey, I know I'm serving this client and it's going to link it to the agency, but that's as far as it's going to go? Here in this example, I'm going to have Jane Doe, she signed the PSYCKES consent form. It was part of the intake package. I included it and we went over it and she signed it. So I'm going to have that be selected. The next question I have to make sure is I'm confirming that this is the Jane Doe. So Jane Doe, yep, that's her address, that's her date of birth, that's her Medicaid ID. I'm going to attest that, yes, this is the correct person, or I could select the other option saying like, nope, she provided me a driver's license or 2 other forms of non-photo ID, and that's how I know Jane Doe is who she is. And then I have my next option of enable or enable and view clinical summary. So if I enable, that just brings me right back to recipient search. But if I hit enable and view clinical summary, that's going to bring me right into the clinical summary. So now you can see that the current PHI access before was no access. Now it's PSYCKES consent. All right, so let's look at what's in the clinical summary. So that's that individual level report that summarizes up to 5 years worth of information. And it's that integrated view of all of those different databases that we talked about. And it helps support rapid review and links those episodes of care to detailed dates of service. And it's organized in sections like an EMR. And here are some of those sections that you're seeing here. So depending on what you're interested in most, you have the ability to actually drop down into that section, or you could take it from the very top to the very bottom. So what we're looking at here is called the brief overview. And this is something that we actually worked directly with hospitals. We got hospitals' feedback on this because one of the feedbacks that we got a few years ago is that the clinical summary is great. It has a lot of information, but I'm in the emergency department. I don't have the luxury to thumb through 40 pages of documentation or scroll for, minutes to make sure I'm understanding the most critical pieces of information. So basically what the brief overview does is that it acts like a cover page to the rest of the clinical summary. So this is pulling in the most critical pieces of information for a certain specific time, and it fits on a piece of paper. And it gives you that ability, and it has these user-friendly cards that help summarize this information for you to be able to rapidly review. So here I'm seeing what's highlighted here is that this is an individual who's complex needs, and I can see why they're complex needs. Not only are they Health Home Plus eligible, but they're that ineffectively engaged individual, and they also have that 4 or more ER mental health services in the past year. So here's an example of what I can see on the brief. I can see that they're Health Home enrolled. I can see their eligibilities. I can see their alerts. I can see any of their social determinants of health in the past year, as well as their active quality flags and diagnoses in the past year. I can also see any medication pickups they've had in the past year and outpatient visits. And then lastly, I can see the hospital and crisis utilization in the past 5 years. So I can see that this person has had a few different types of services in the past 5 years when it comes to the ED visits, inpatient stays, and crisis services. Now I'm at the full summary, and I also have the ability to export this information in a PDF or an Excel. So up at the top, you're having that general information. This data is all scrambled for, training purposes, but these are going through those same exact sections that we were just looking for before, the current care coordination as well as the notifications. If I keep scrolling down on the page, I have the ability, unlike the brief, is as I want to drill in for more details, I have that ability to do so. I can go into each of these different rows here, or I could select the different conditions for social determinants of health to get a better understanding of those unique days. Like, so if I wanted to know each treatment for suicide ideation, those 9 different times, I have the ability to drill in there to do that. I can also look at all of the quality flags that this person actively has. And if I'm not exactly sure what the definition is for some of them, I can always drill in and find out more information. So here's an example of me drilling into one of those sections. And this example is the behavioral health diagnoses. So I can see that this person is most frequently diagnosed with schizoaffective disorder underneath their behavioral health diagnoses. So what I can do is I can select that, that specific condition, and what I can see is the date of service associated, the service type, the service subtype, the provider name, as well as any other diagnoses that they were provided during that visit. We can also look at the integrated view of services over time. And I think this is such a great tool because this allows you to see this information in a visual way. So it helps you spot patterns or issues in certain aspects, right? So like here an example is there's this break in medications, there's a break in some of the outpatient services, and I can see a lot of the ED and inpatient actually picked up during that time. So maybe I can say like when people aren't on their medications, or if they're not seeing their outpatient services, that's when their hospital utilization kind of picks up. And as you can see here, if I hover over any of these, either dots for a single service or rows to indicate, continuous service, I have the ability to see that here. I can also see that this person had a break in their Medicaid enrolled status and came back a little before July 2020, it looks like. Then we have the ability to look at the medications, and those are broken out into the controlled substances, behavioral health, as well as medical. And you have the ability to drill in and see these pickups on based on order. So individual pickups you could see for certain medications here. Then we have the outpatient service. So that tells you the service type, the name of the provider, the first and last date billed, how many visits they've had, as well as most recent primary diagnoses and any of the procedures associated. We also have a crisis services section. So this is going to indicate if somebody had mobile crisis, CPEP crisis, crisis intervention, either doing the telephone or mobile crisis response, and then also crisis residential stays. So this information is going to show up in the crisis services section. And just like the outpatient information, right, you'll see the name of the provider, first and last date billed, length of stay. And again, if this was a residential stay, that might have a few days, but mobile crisis response usually a day. And then the diagnosis and procedures provided. And then we have our hospital ER services. So this is letting you know, like, what is their utilization looking like? So here I can see that they actually were very recently in the New York Psychiatric Institute for a 35-day stay. And we can see that they've had a few different ER visits as well, even an extended observation bed stay back in October. So we can see that this person had quite a few different hospitalizations. All right, so I see we have about 15 more minutes to go. So I'm just gonna try to power through a couple more of these slides here and make sure that we have time for questions. All right, so what is the MyQI report? It's a tool for managing quality improvement efforts. And within the quality indicator report, we display the eligible population for each of the different indicator sets or flags. And what is the eligible population? Another way to think about that is the denominator. And this is the number of clients served by your organization in the past 9 months plus any other parameters depending on the quality indicator specifications. So that's something that, again, depending on flag to flag, might differ. The number with the QI flag, that's known as the numerator. That's going to be the number of the people who are actually hitting the criteria for that quality flag. And what we do in PSYCKES is we're providing you what we call maybe the not so good news, right? Certain applications show people are hitting criteria, are getting the follow-ups that they need, or getting, the medications that they're supposed to. Whereas in PSYCKES, we're showing the opposite of that. And the reason why is because then you can drill down to that client level information and then hopefully make some interventions or being able to intervene and help that individual. So basically what you're going to be seeing after you're looking at the eligible population as well as the number with the quality flag, then what you're going to do is seeing the prevalence rate. So that's just another way of saying numerator over denominator. And you have the ability to compare your prevalence rate against the region and the state. And in PSYCKES, again, you want to see that prevalence rate, you want to see that lower, you want to see that go down over time, even if that's a little bit different than other applications, because the lower the prevalence rate, that's the better that you're doing at that particular indicator. A high prevalence rate indicates that there's an opportunity for improvement. You also can filter the different, you can filter the MyQI report on different types of filters. And one of the new filters that we recently added was the complex needs population. So you're going to be able to filter each of the different indicators based on the people that you have served in the past 9 months who are also considered complex needs. All right, and then you can drill down, as I mentioned, to see the recipients who match the criteria, and all of our reports can be exported. So before we look at some of the MyQI reports, I just want to make sure that we all understand what the MyQI report itself is. So one of the things we want to make sure that folks are always understanding is how clients are going to be attributed to your hospital in MyQI report. So clients are going to be attributed to your QI report through billing. So clients who are linked to your hospital, if they've been billed anywhere in the hospital, whether it be the clinic, inpatient, et cetera, if they've been billed in your agency in the past 9 months. So that rule is used to automatically link clients to providers. So current clients are included on the report each month. Now, there is also the period of observation. So this is assessed by each measure and varies for each measure. So for example, the period of observation for the high utilization quality indicators is going to be 13 months. So the as of date from the MyQI report is going to show you the as of date. So you're going to be looking back 13 months from that. And then we also have the, oh yeah, that's exactly what I'm saying there. So that's just a couple different ways to understand the MyQI report. First, how people are attributed to your organization, and then what the period of observation is per flag. All right, so now we're looking at the Main Street Hospital, MyQI report. So what we're highlighting here is up at the top is the quality improvement indicators. So these are more of our quote unquote real-time measures because we're able to run this on a monthly basis. And when we took these screenshots, it was from our most recent version, which was back in November. We're gonna have our December refresh at the end of December, early holiday gift, and that will be as of 12/1/2024. However, as we mentioned before, DOH runs their measures with an intentional lag of 6 or more months to allow for complete data because, as we know, the billing information can sometimes have lags, right? So that's something just to, when you're looking at the MyQI report, is a little bit of the difference there between the as of time frame. So that's always good to keep in mind. And then we're seeing here, like, what's the eligible population, right? For, like, let's say the high utilization. Here's the eligible population, the denominator. Here is the people who are matching that quality flag. And then here is the prevalence rate. So about 40% of the people have high utilization that we're seeing here. And we can see that's a little bit higher than the region and the statewide. So that might be something I think is a room for improvement. All right, so now I'm going to drill in and see like, okay, that was just the entire indicator set. Let's see how my performance is per flag, per indicator type. So we can see here for this 10 or more ER all cause that of the 20,000 plus eligible population, about 560 have this flag of having 10 or more ER visits in the past year for any reason. So what happens when I want to apply a filter to this? So let's go ahead and put the filter. And now with this new population filter, now I want to aggregate this report by which clients that I've served in the past 9 months are also considered complex needs. We know about 560 clients that for the whole population, right, hit that flag. So now I want to compare the complex needs folks. So now that 560 got cut a little bit in half, right? So we have 288 people now hitting that criteria. And I can compare myself to the region and the state with those numbers as well. And then let's say I want to go that extra mile. Again, like, okay, of the people who have 10 or more ER visits for any reason who are also complex needs, now
Hey, Kristen, I'm having trouble hearing you right now. I'm not hearing any audio coming through.
Yeah, likewise.
Looks like she's calling back in, so please hold. Thank you, everyone, for your patience.
hi folks, can you still hear me now?
Yes, we can hear you now.
You're good,
Oh,
thanks.
sorry about that. Where did you lose me?
Just a couple slides ago. Maybe just start at
couple.
statewide reports. Yeah.
Okay, let me back up here. Thanks for always the technical issues
Right
during
there.
the WebEx, right? All right, so now we're going to talk about the statewide report. So this is a great way for you to have the
Oh, no.
Okay, that is the strangest thing. The WebEx just muted me. Can you guys hear me?
Yes, we
We
can.
got you now,
Yes.
thanks.
Okay, goodness gracious. Okay, fingers crossed. We only have 7 more minutes. We'll make it. All right, statewide reports. This is your ability to indicate here in the indicator set what you're interested in looking for. So here's an example that we're going to do the 4 more inpatient ER mental health flag. Maybe that's what I'm interested in, you know, seeing on that statewide level. But I also want to make sure that I have a fair comparison, right? If I'm a hospital, maybe I want to compare some of these hospital-related flags to other people who are providing these same services, right? Obviously, people are going to have higher flags for hospitalizations for people who are working in a hospital than maybe somebody who's working in like a different kind of clinic, right? So now I can compare this report for any other, you know, folks that are providing any ER behavioral health or CPEP services. So now I'm running this report like that, and then I can add that complex needs flag. So now the statewide report that I'm running here is saying like of the people who have 2 or more inpatient or 2 or more ER flags that also have a program type of the ER behavioral health diagnosis service or CPEP, how many also have a population with a complex needs? Like I want to see like how other people are doing with this type of population. So when I go into my statewide flag, again, I have the ability to drill down and compare the prevalence via region, county, network, provider, or plan. Here's an example of me looking for the providers and I'm comparing myself. So let's say that I'm hospital B and hospital A, they have a higher prevalence than me, and so does hospital C. So even though my number, I might be like, oh, that's kind of a high number, but I compare myself to other providers that are providing similar services to me, maybe I feel like, oh, I'm actually doing pretty okay. So that's another way for you to run this kind of search. So I'm just going to also just briefly touch on the utilization reports, because these are basically created to help providers identify other organizations that they may want to link with, because it gives them an opportunity of seeing what other providers am I sharing clients with, or what are my managed care plans and product lines that my clients are enrolled in, or what services are my clients utilizing, whether it's from my hospital or other providers. So here's where I can see the breakdown for my hospital, like of the people that I've been servicing, who have what type of managed care plan, or are they fee for service, right? So here's the way that you can break down those different managed care plans as well as their product lines. You can also do in the provider network, right? So maybe I'm interested in seeing, like, of the people who I've served in my hospital, where are they going for their outpatient mental health services? Because maybe I want to connect with them and make sure that I have that connection, especially for follow-ups after discharges. You have the ability to filter this report, or sort this report, I should say, and I can see of the people that have been served in Main Street Clinic, maybe I want to bring them to, the USP Capital District or Parsons Child and Family Center, because they're managing quite a few of my clients. And then I can also see what other types of services these folks are getting. So for my Main Street Clinic, right, I'm not going to be providing maybe some of these after core services, but I can see who is and where those services are going, right? All right, so I know that we only have a couple minutes here, but again, for any resources for PSYCKES, our website is just a treasure trove of user guides and other training webinars, and it's a great place for you, especially if you're getting started. And if you have any questions about how to use PSYCKES, or if this search can be done in PSYCKES, or I'm seeing this data in PSYCKES and I'm not sure I'm understanding it, please reach out to our PSYCKES help desk. We're available 9 to 5, Monday through Friday, and you're going to get a response within 1 business day. But if you're having issues logging into PSYCKES, if you have an issue with your token, or you're having trouble logging in, you're getting an access error message, what you'll want to do is you want to contact the ITS help desk, and we provided those different accounts here. So with that, and I'm so sorry for that technical issue a couple minutes ago, because I hope it didn't cut into our question time, I'm going to turn it over to Michelle to see if there's any questions that came in.
Hey, Kristen, there actually were no questions that came in during the webinar. You explained it all so well.
I hope so. I hope everybody's so riveted. But again, for folks, in case they didn't hear this in the beginning, we are going to be providing these slides and this recording to everybody who attended today. We're also going to be posting this recording and this training to our public website. So if any of your colleagues unfortunately had to miss out today, couldn't join today, please feel free to forward them the slides or direct them to our website, because we're going to have this available there. And with that, I guess I will I'm going to hang out here for a couple minutes in case there's any other questions that come in. But for everybody else, thanks so much for taking the time to join us today. I know during the holidays, there's a real time crunch, so we really do appreciate you taking the time to learn more about this tool. And with that, happy holidays and thanks so much.